You look at the way we think about acute coronary syndrome and myocardial infarction, every medical student, every intern knows the differential diagnosis for chest pain. And inherently, they get taught this notion of angina pectoris. And we use angina pectoris and the symptomology along with biomarkers and diagnostics to thoughtfully assess patients with acute coronary syndrome. Now, in my world of biomarkers, there's a lot of troponin worship. Troponin is held up as the uber gold standard for all biomarkers. It is to which everything else is compared. But if you take troponin outside of its appropriate context, whether it's a patient in the emergency room with chest pain, it begins to massively deteriorate. And anyone who works in an intensive care unit and has watched their intern or fellow or medical student get a troponin, particularly in a septic patient, for really no good reason, ends up with an increased value. These patients don't have ACS. Their troponins are elevated. And when you actually assess the performance of troponin in these patients, only about half of them, when they're adjudicated, have any kind of true acute coronary syndrome. The other half have renal failure, sepsis, and a whole host of other diseases. So when you take troponin outside of where it ought to live, it becomes an incredibly poor performing diagnostic. It's not good for acute coronary syndrome anymore. And the point here is that context matters. Context matters enormously, right? And you can ask every cardiology fellow who spends half their day tracking down borderline troponins on how good a diagnostic it is for them when used in an inappropriate patient population. The data assessing troponin as poor performance, if you get out of context, is everywhere. Typically, sepsis, infection, renal failure are the causes of elevated troponins that have nothing to do with acute coronary syndrome. It doesn't mean the patient isn't having stress on their heart. It doesn't mean that they're not having myocardial necrosis at a very small level. But they do not have acute coronary syndrome. They are not going to the cath lab. They are not getting stented or PCI'd. So, in conclusion, troponin's performance massively deteriorates when it's used outside of the angina pectoris paradigm. And we have been looking at AKI biomarkers, and they do pretty well, but they don't seem to reach the threshold of troponin. And troponin's threshold on an ROC curve value is around 0.91 to 0.93. And we do things with acute kidney injury, we seem to be stuck in this 0.8 range. And the question is, well, is it the markers that are bad, or are we using the wrong context? Because what we hold acute kidney injury biomarkers up to is all ICU patients. Throw them all in, do the biomarker, make it work. Well, if you did that with troponin, it wouldn't be an FDA-approved biomarker. You wouldn't be using it because its performance in an intensive care unit is around 0.75 to 0.8. It's atrocious compared to what it does when contextually used properly. So the idea is that maybe we can do better by developing the context. So is this renal angina? No. Right? Of course not. Simply put, acute kidney injury doesn't hurt. Chronic kidney disease doesn't hurt. Hypertension doesn't hurt. Many of the diseases that we take care of, these patients do not feel pain. So the idea is that can we generate a context that's appropriate to identify patients at high risk? Now, we could have called this renal risk. We could have called it a whole host of number of things, but we called it angina for a reason. And it's because of the way angina pectoris is developed and how we get there to develop this process. And I'm going to show this to you. So we know the classic Framingham risk factors. We take those risk factors on the left, we add them to the clinical syndrome, which is the various forms of angina pectoris, and we put this together in our heads, and we come up with an assessment, right? And the classic thing from a cardiology attending to a fellow or another clinician is, do they have a good story for angina? Do they have a good story for chest pain? What's the story? What kind of pain is it? What is the character? Do they have jaw pain? Do they have nausea, dyspnea? Things which are not pain per se, but symptoms that make you think and wonder, could this be cardiac ischemia? And so we add these together and we develop a threshold. And the same thing can be done for renal angina. We know the risk factors. We know them very well for adults. We know them for children. But the question is what is the anginal equivalent if we don't have pain and symptomology? And what we decided is that the best way to do this using the same type of system, and remember, this is angina, right? What we did is we deconstructed angina pectoris to reconstruct renal angina, which is why the name suits it, because it's based on the same construct intellectually. And so what we did is we developed various hazard risks based on your risk factors. So you have 1 or 2 risk factors, 3 or 4 risk factors, or lots of very severe risk factors. And as we know clinically, all chest pain is not equal. So if this gentleman walks into your ER, this is Orson Welles for those of you who don't follow. He was an enormous man who smoked constantly. If he walks into your emergency room with a little bit of chest pain, a little bit of reflux, a little bit of burning, he is going to get admitted. He is going to get a stress test. He's going to get an EKG. He's going to get a full workup. If Michael Phelps comes into your emergency room with the exact same symptoms, he's going home because he doesn't have risk factors. You're not worried about him. It's the same pain. Similarly, does a 0.1 milligram per deciliter change in serum creatinine, is it meaningful in a patient who has been home with mild diarrhea, who came to the emergency room because he wasn't feeling well, as compared to an 82-year-old person with pneumonia and hypotension? Those are two completely different things. The symptom is the same, a very small change in serum creatinine. If you allow that small change in serum creatinine to mean the same thing for all the same people all the time, it becomes meaningless. Context is critical. Similar to the way we do angina pectoris, we use renal angina to do this risk assessment. So how do we do this? Well, instead of using chest pain, dyspnea, which is not pain, or nausea, which is not pain, or other things which are not pain, what we do is we're using small changes, subclinical changes in serum creatinine and urine output. And this is essentially what you have. You have a group of patients who have lots and lots of risk factors, right? And they have a very small change in their serum creatinine. Right? This is a patient with pneumonia, sepsis, showing up to the emergency room very sick. You have a group that has a few risk factors and a more moderate change in their serum creatinine or urine output. And you have other patients who are really quite healthy, very few risk factors, but have significant changes. And the idea is that in aggregate, these 3 groups are essentially equivalent in their AKI risk, which we term renal angina. Exactly the same construct as angina pectoris. Risk factors plus the story of the pain, the story of what's going on with the patient. And so as you walk up the level of risk factors, the threshold is changed to adjust accordingly so that you're not stuck on a single number, on a single delta, chasing your tail in the absence of context. In clinical medicine, if you want to be a guideline-driven computer, big data, have the PA see the patient for you and phone it into you, that's fine. But if you're going to see the patient and specialize, optimize, and personalize your care, this is how you do it with context. So this is the hypothesis. The first hypothesis is that these different risk groups, or tranches, should have equivalent performance. Lots of risk factors, small changes in serum creatinine urine output, not many risk factors, larger changes. That's hypothesis 1. The second thing is similar to angina pectoris. It should have a high negative predictive value. You should be able to rule patients out. If you look at angina pectoris and patients who come in with chest pain, many patients with that kind of symptomology get ruled out. But the key is not to miss anyone, so the sensitivity is set very high. The negative predictive value is very high. This is what creates value added at the bedside, and this assessment, by the way, is pretty much free because you're clinically assessing them anyway. You should be able to rule them out based on this. And most importantly, what you'd like to see, part of the reason that Stu Goldstein and I developed this, is that it should improve the performance of acute kidney injury biomarkers. If our hypothesis is correct, then renal angina should have a performance of an AUC of around 0.75 to 0.85, and when added to a biomarker, it should bring us into the land of troponin, something above 0.9. So let's put it to the test. This has been out for a while. We've done some work on it. These are data that was published by Claudio Ronco's group looking at a large Italian ICU data set. And what they did is they looked at around 500 patients in a large set, and they looked at these various tranches and to see, does it perform as advertised? And what they found is that among the 3 tranches, the sensitivity is all exactly where it ought to be, somewhere between 90 and 95%. Similarly, the negative predictive value is outstanding. So the model we proposed was then taken from the U.S. to Italy, and it performs just as well in Italian ICU patients as it does in patients in the U.S. as well. So this is something which is very encouraging. Stu Goldstein's group of Cincinnati Children's with Raj Basu similarly took the pediatric criteria. They used a renal angina index where they took the various risk factors and the small changes in either creatinine clearance or fluid overload and developed and validated a score. So this is now highly quantitative. And if you're above 8, you are positive for renal angina. And they found the exact same thing, a very high sensitivity with an excellent negative predictive value and an area under the curve of around 0.77 to 0.8. This is about where other AKI biomarkers perform, by the way. So just putting your head together, looking at clinical risk factors, gives you enormous value at the bedside. So this is now data which is unpublished, and I really want to thank Stu for allowing me to show it. This is looking at a very large cohort of over 5,000 patients looking at renal angina. These are 5,000 children. I just want you to understand how huge an undertaking this is. And the ROC curve value, as shown in the preliminary data, is exactly on point, which is around 0.8. And so we know that it performs well, and we can use it to rule out insensitivity. But what about the most important piece of this puzzle? Is does it improve the performance of AKI biomarkers? This is where the rubber hits the road. Does this actually get the job done? It turns out it does. This is similar work out of Cincinnati Children's with Stu Goldstein, Raj Basu, Mike Napatelli, looking at a large cohort of patients, renal angina positive, right back where we were, 0.8. These are all new cohorts. These are not the same data being recut. And when you add biomarkers to them, whether it be NGAL, elastase, MMP8, it improves. It gets very close to 0.9. And in recent data, which is currently under review, Stu Goldstein's group has done this with Cherub, another separate independent cohort, renal angina, ROC curve value 0.8. You add it to urinary NGAL, it goes to 0.97, which exceeds the performance of troponin. I'm going to say that again. It exceeds the performance of troponin. So what we have here is a system where in the hypotheses of renal angina being able to perform and do what it ought to do, it does. It works. Now, let's talk about the case against renal angina. So the biggest first complaint is that it's a biologic variable to define a pre-disease syndrome, and so it's inappropriate. So you can't use a small change in serum creatinine to then define a larger change because these things are essentially mathematically coupled. And another big complaint about this system is that the words don't mean what they're supposed to mean. Angina means ischemia. And then we wrote back and said, well, actually it doesn't mean ischemia because there's Ludwig's angina, which means pain. And then the complaint was, well, AKI is painless, so you shouldn't use angina because it always means pain, except for the fact that you can have dyspnea and nausea, which is also not pain. So we get into this sort of large sort of circle of semantic conversation. But in the end, let's take the first case, which is this issue of being able to use a number to define a disease, which is used a number. And I thought, let me think, is there a disease that we use some sort of number to help define it? And I thought really hard. It must be a rare disease. And I thought, well, 5 seconds later, there's diabetes. And you have patients who are pre-diabetic. And if you're above 7%, you're diabetic. If you're below 7%, you're pre-diabetic. And if you're below 5.5%, you're good to go. And I don't hear a lot of people complaining about their ability to use hemoglobin A1C in the management of diabetes. It appears to be quite straightforward. So I think we can dispense with this notion that this biologic coupling is something which we cannot use in clinical medicine, given the fact that most of our patients are diabetic and it works quite well. The other large part is this notion about what's in a name. Now, Claudio Ronco accused me yesterday of becoming more Italian, which I thought was actually a tremendous compliment. And there is this notion of Italianization, which is a true thing. And Trieste, which is a city up in the corner of Italy, was originally in Slovenia. And it was Italianized. It was taken over by Italy. And there was a small suburb outside of Trieste called Prosek. Prosek was originally a Slovenian town, and there was a famous dessert wine, a very sweet wine that was made there. It was Italianized, and the name of this town was changed to Prosecco. And we all know what Prosecco is. It is Italian sparkling wine of Glera grape origin. And how many of you knew it was a Glera grape? None of you. And the Slovenians are not so upset about this word being taken from them. They seem to be handling it quite well, in fact. They have not declared war. There hasn't been a large escalation at the World Trade Organization over this. This is the region for where Prosecco is made. It happens to be here in the Veneto. For those of you who get a chance to spend some time here, I have been very, very privileged to be attending this meeting over the past couple of years. So I've had the opportunity to be here. And I assure you, Prosecco is outstanding. So this notion that we cannot use new words to mean new things seems a little bit off, because no one appears to be confused with Prosecco at all. It's really quite straightforward. So this notion that the words mean something and it's confusing and it started as a dessert wine, but now it's a dry Italian wine, and no one's going to be able to understand it, I don't know. It tastes just great to me, and it's Prosecco. So I think the case against renal angina based on this sort of semantic issue of do numbers being confounded or using new words, I think doesn't make a whole lot of sense. But I like to point out one very important thing, which is that if you like the term renal angina, you will love Prosecco. And if you haven't tried Prosecco and you're allowed to have it, I encourage you to try some. If you do not like the term renal angina because the name is somehow too complicated for you to manage, you are still allowed to enjoy Prosecco. That's the good news. But in order to remain intellectually consistent, when you drink your Prosecco, you must say, I like this beverage, but the name is wrong and it's confusing. And it should be referred to as Italian sparkling wine of Glera grape origin. Every time you drink it, someone else is drinking it. And that is a purist view, but really it's a canard. This notion that we can't understand what the word means amongst a group of highly educated physicians, nurses, and healthcare professionals seems to be dramatically at odds with the typical complexity of which we deal with. And the construct of angina is highly accurate insofar as it was a deconstruction of angina pectoris. And if you note in the literature, it's not just angina. The initial utilization of the word angina is consistently angina pectoris, delineated and differentiated from other forms of angina. So it's not limited to ischemia. It's not limited to other things. And so renal angina is a framework to assess pretest probability of acute kidney injury. In retrospective studies, renal angina has excellent sensitivity and negative predictive value. In prospective studies, renal angina significantly improves the performance of AKI biomarkers in a range consistent with troponin. Now, I should say that all this data for the improved performance has primarily been done in children, and we on the adult side need to learn to catch up with how well the pediatric nephrologists have done. And none of this would be possible without my good friend and colleague Stu Goldstein, and without their work and their incredible work they've done in actually doing the validation, we wouldn't be where we are. So I'd like to thank Stu personally, and viva Angela. Thank you.